So this session is to honor Dr. Nick Hopkins. So if you go on, so I didn't introduce myself before. So I'm Dr. Sherman. I'm the chair of the history section. And we started this Leaders in Neurosurgery interview series a number of years ago. And if you go on the website, you can get access to that. We're up to 36 lectures, actually 37 there are two separate interviews of Dr. Hopkins, one by Dr. Alad Levy and one by Dr. Anand Siddiqui. And so this event today was meant to be a in-person lecture or in-person interview between Dr. Levy and Dr. Hopkins, but unfortunately Dr. Hopkins passed recently, and the thought was that we would honor him through a forum panel discussion between people that knew him best. So this is just some background on his history. I'm going to get through the slides quickly, but the idea was really to have an open discussion, an open conversation about really what he meant to his trainees, to his friends, and to the world of neurosurgery. So Dr. Hopkins was a founder and chief scientific consultant at the Jacobs Institute. He was founder of the Kaleida Health Gates Vascular Institute, professor and chairman of the University of Buffalo Department of Neurosurgery, and professor of radiology at UB School of Medicine and Biosciences from '89 to 2013. He was appointed the SUNY Distinguished Professor and highest rank of faculty in the SUNY system in January of 2013. Undergraduate studies were at Rutgers, medical degree cum laude at Albany Medical College, and postgraduate training, surgical internship at Case Western Reserve Neurology and Neurosurgical Training at UB. He pioneer in endovascular neurosurgery, member of the board of directors for the AANS, executive committee for Stroke Council of the American Heart Association, scientific and annual meeting chairman for both the AANS and Congress of Neurological Surgeons, former chairman of the Joint Section Cerebral Vascular Surgery and president of the American Academy of Neurological Surgeons, and principal investigator of several national clinical trials testing catheter-based technology and treatment of neurovascular diseases. So author of more than 300 publications centered on the prevention and treatment of stroke. So we have four panelists today as part of our discussion, first of which is Dr. Levy. Currently serves as the chairman of the Department of Neurological Surgery at the Jacobs School of Medicine and Biological Sciences and professor of neurosurgery and radiology. Dr. Stephen Giannotta, professor of neurological surgery and former chair of the USC Keck School of Medicine and Department of Neurosurgery. And this is a picture Dr. Giannotta provided, which is the travel group that Dr. Hopkins was part of. There were many pictures I could have included, but the point of this was really having a nice discussion. So I thought this was poignant for something that meant a lot to him, and I appreciate Dr. Giannotta providing this. Dr. Adam Arthur, chair of the Department of Neurosurgery in the College of Medicine at the University of Tennessee Health Sciences and director of cerebral vascular and endovascular neurosurgery for Sims Murphy and UTHSC Department of Neurosurgery since '09. Errol Vinzenoglu, I'm going to pronounce this wrong, I apologize. Vinzenoglu, I hope I got that right. Professor and director of Drexel Neurosciences Institute for Drexel's University College of Medicine and the Robert A. Goff Chair in Neurosurgery at Global Neurosciences Institute. And so the first question really relates to kind of the pre-Hopkins era, right? There was, what was the general thoughts of cerebral vascular neurosurgeons on the role of endovascular techniques at that time?
Yeah, great question. We asked ourselves the same thing back then, and I'll refer you back to that picture that Dr. Sherman showed about the so-called travel club. We called it the travel club, thinking we invented travel clubs. We didn't, but we took the credit for it. But anyway, I'll also refer back to that first slide where it showed that Nick was chair of the Joint Section of Cerebral Vascular Surgery. The only members of that section back then were doing open vascular surgery. And if you remember what that picture looked like of those travel club members, there was a fair number of vascular neurosurgeons in that. Duke Sampson, there was a fair number of major personalities in that picture, including Art and Duke and, of course, Robert. And in about the late 80s, when Nick became the president of the Joint Section of Cerebral Vascular Surgery, I was the secretary of the Joint Section of Cerebral Vascular Surgery. And at that time, we had 4 or 5 years of our travel club, and we kept asking, Nick, what are you doing? he was generating jillions of miles on American Airlines, flying around the world, talking to cardiologists and neurologists and trying to talk them into engaging in this neurointerventional. They said, we all said, Nick, we're just trying to get a little bit of control here, and now you're going to dilute it all over the world. Well, the rest of course, is history. And so when he was chair of the joint section, he said, Steve, here's what we got to do, meaning here's what you got to do. We need to make the AANS and CNS allow us to have non-neurosurgeons in the joint section. And that was the great mixing bowl of what we, of course, understand today in terms of our colleagues at doing neurointervention. He says, you're on the executive committee of the Congress, so your job is to go over there and get that done. And then fast forward, I thought, okay, so then fast forward 25 years, and then I find myself on the other end of things in terms of validating the training of all of our colleagues from these other disciplines. So it's a heck of a story. And it was very gratifying this morning to hear Nick acknowledged, and I guess he's going to be acknowledged again tomorrow. So, yeah.
So in between those 25 years to forward to around 2000, you know, I remember the first case. I was a fellow. It's 2001. Someone comes in with a basilar occlusion, and we're putting out wires and nonsense, and the patient doesn't do well. And Nick looks at me and he says, if cardiologists can do this in the coronaries, we can do this in stroke, and we will and we can. So, you know, in the era before endovascular, there were two places, Jefferson, where Errol trained with Rosenwasser, and then in Buffalo. But really, Nick and kind of these Gen 1 guys saved cerebrovascular for neurosurgery. He saw that if we didn't take care of stroke, which is the most predominant disease in cerebrovascular care, if we didn't learn endovascular techniques, carotid stenting, coiling, we were out, right? This cerebrovascular disease was not going to be part of neurosurgery anymore. And people were recalcitrant, right? They did not want to hear this. And now fast forward to the ASITN meeting, which no longer exists. It's now SNIS. And I stood up, it was around 2004, and gave the first case of stenting for an MCA clot. And I remember I was sort of chest out, beaming. I'm like, I'm gonna shock the world, right? People are gonna see this and they're gonna be amazed. So I show this case, and then a famous chair at a Philadelphia institution, Penn, stands up, and I think he's about to give me the biggest compliment of my life. And he says, if I had a tomato, I would throw it at your face. I wanted the ground to swallow me up. And then with groupthink mentality, everybody stood up and told me how terrible cowboys, renegades, criminals, you think, and I went back to Nick and I said, Nick, they hate us. I'm like, what are we doing? And he said, you know, if it didn't cause a visceral reaction, it's probably not worth doing. Keep going. And then 2015, new standard of care in stroke, paradigm shift, flow diversion, everything that's part of modern day cerebrovascular. You know, I have to give credit to that guy up there. Just such a visionary.
Yeah, I mean, I would echo both of the last statements. So I had a unique perspective. I was a medical student at Buffalo, so I didn't know anything. I thought, yeah, it's an aneurysm. Neurosurgeons do endovascular, and they do the open. And then I went to Jefferson, where, again, it was same concept. And I think the 2 points there are that we were the first generation, really, of going out there based on their shoulders of, you know, pushing things forward and realizing that not everyone had quite adopted this yet. And I think we all had that experience in lots of ways. I thought that my career was over very early, very on with some of these talks because we didn't have any sense of reference. But I think Dr. Giannatta's point, Dr. Spetzler and Dr. Hopkins were very, very, very close friends. All of you guys were. You guys were brothers, you know, and at that time there was, you know, now it's brothers and sisters where there was this kind of, but Nick was always ahead of the game. And I think for the younger people in the audience, think about the things that we're doing today, and it's really important, and this I will give 100% full credit to Nick, is we're treating subdural hematomas endovascularly. We're doing MMA. Think about that. I mean, I still, when I think about that, like, and I'm was pretty pro endovascular. I'm like, wait a minute. Pseudotumor cerebri, we're treating endovascularly. The great lecture that we just had, functional neurosurgery, stent trodes. We're putting stents in the sagittal sinus to do deep brain stimulation. That's all Nick, and that's all neurosurgery.
I think John's got other questions.
Yeah, so that was a great start. Appreciate that. So you kind of inferred this a lot about kind of what other people were thinking at the time and some resistance. So what resistance was present? I have 2 points. One, to incorporating endovascular techniques, and two, for neurosurgeon performing these techniques.
I think there's still resistance. We're still on that road. Kevin Foley is one of my partners. He's a spine surgeon, and he believes we ought to be teaching catheter endovascular techniques to every neurosurgeon in training because of the future and what's coming. And he doesn't understand why we're not doing it yet. And I don't know, that's maybe something Dr. Giannotta can answer better than I can. And when we come with new ideas, there's still tremendous resistance. When I wanted to gain sponsorship to run a randomized controlled trial for subdurals, I fought for 9 months to get the largest medical device company in the space to do it. I did a survey of 30 neurosurgeons. I had 80% tell me they wouldn't randomize any patients into it. It was crazy. You just knock a hole in the head and drain the subdural. I couldn't even get done with the 310-page randomized trial before I had people complaining that they couldn't randomize because they knew for sure you just needed to embolize the middle meningeal artery. I'm very interested in the fact that our treatment of different peoples is not always the same. And so migraine doesn't kill people. It mostly affects women. It's just headache. Send it to the classic archetypal bow tie neurologist. And some of those patients get good treatments from migraine, but a lot don't. So if we were more logical, if we were like Nick, if we said the cardiologist can do it in the coronary, so we should be able to do it in the basilar, I might suggest that if an AI algorithm in med school decided who saw what patients, and I told the AI algorithm that this disease is related to a specific piece of tissue that's really easy to get to surgically, and it is, it's related to the microvasculature of the dura, we wouldn't send them to a pill pusher. We'd figure out something either surgical or endovascular to do about it. So I firmly believe that in the next 5 or 6 years, Nick's going to get a big kick out of it as he sees migraine, emigrate into the endovascular labs. I'm not sure exactly what it's going to be, right? We just 3 weeks ago published our first series using lidocaine, which is really interesting. Did a couple cases before I got on the plane to come here, and I still don't understand what's happening, but it's happening. And then we've got the first open IDE to use embolics. And maybe it'll be Dr. Gross with some kind of electrode stimulation thing that I won't ever understand, just like I did when I was his resident. But there's going to be something that attacks the vascular network in the dura that's going to do something for all of these people that we've really not done good enough for. So the resistance has always been there. The resistance is still there. And, Nick's personality and his laughing, if you're not going to get a visceral reaction, it's probably not worth doing, is part of the DNA of this field that pushes us to continue to take the direction he led us in and do new things.
And that's great. I mean, from a resistance standpoint, that's how I ended up in Buffalo. So Doug Konzioka, past president of the CNS and past director of the board, was my program director at Pittsburgh. But I wasn't going to be able to get endovascular training at Pittsburgh. It was run by radiologists at the time, and I was forced and did the first infolded, you hear about infolded fellowships, up in Buffalo, but the resistance isn't part of the history. It happens now. At this meeting, a prominent cerebrovascular surgeon said basilar aneurysms should never be coiled. At this meeting in 2025. Can you believe that? So what we're hearing in 2025 is not different from what we heard in 1980. So that kind of rhetoric, right? Until that rhetoric changed, and as Dr. Giannotta, one of my former chairman at Pittsburgh said, real change happens when a generations of neurosurgeons dies out, right? That's when real change happens and new ideas sort of become the standard.
Yeah, I mean, I think not to beat it to death, but to answer the question, 25 years later, I think it's still within where the resistance is. But again, for the younger generation out there, which there's a lot in the audience, which makes me happy, we're at a time now where the world's moving on. We're not going to be able to wait for people to the next generation. The world's moving ahead of us. It's a really exciting time in healthcare right now to be able to embrace these things. But to put it in perspective, for all the old folks like myself in the room, you think about radiosurgery. I mean, when radiosurgery was, this isn't neurosurgery, how can you treat, these disease entities with radiosurgery? Instrumentation. I mean, some of the younger folks don't realize neurosurgeons never did instrumentation. That's what the orthopods did. When I was a resident, we did the decompression, and the pods came in and threw the screws in, and now it's part of core curriculum. And to Adam's point, we have to make, it's not endovascular open radiosurgery, it's disease treatment. And that's really, you have to have all those tools in your belt. Oh, sorry.
Just a little bit more about the resistance. One of the things that partially at least mitigated that resistance is something I talked about, which is incorporating other practitioners in the art form, namely neurologists and radiologists. And we figured that out a long time ago at USC. In 1994, I hired 2 endovascular trained radiologists, trained at both of whom trained with Randy Higashida and his pals up at UCSF, into the Department of Neurosurgery. And I had a willing partner in this deal, and that was the chair of radiology, who, if you remember the history, Randy figured out CD codes and all of that, and those people, those neuroradiologists up there were making a ton of money, way more than most neurosurgeons were making at the time. Obviously, that's all mostly gone away now, but the chair of radiology said, Steve, I can't pay those guys, so go ahead, put them in your department. And since that time, we've always had neurologists in our department. We have 6 people in our vascular division, and 3 of them are not trained as neurosurgeons, so there are ways around it.
Yeah, and when you mentioned novel therapeutics, I mean, the things that were, even in glioma work, we're bringing on, even at Rutgers, an IA chemotherapy for Avastin, which, interestingly enough, when we talk about the systemic effects, which is not tumoricidal, but in IA, in direct injection, there is with Avastin, and we would never have had that opportunity if to maybe have a better efficacy with treatment with something novel like that. It never occurred to me. Now I'm working with my endovascular colleague on getting that trial on board, and so it's kind of a fun thing that we now have access to. But there's still resistance because there's going to be people out there that aren't going to be believers, and it's been a tough road for that particular therapeutic road because of that resistance, and we're having to work with endovascular colleagues and how that would even make sense.
Yeah, finally, we have our neuro-oncologist in the Department of Neurosurgery and our movement disorder trained neurologist in the Department of Neurosurgery with the willingness of the chair of neurology. So it's another way to skin a cat.
So the next question is, so this is for each of you, how did Dr. Hopkins impact your life, either personally, professionally, or both?
I'd love to start with that, because this is something I said at Elad's meeting when we had a memorial for Nick, sort of ahead of time. And this is involved with the history section, right? So I think if you're familiar with neurosurgery and you read Michael Bliss's biography of Harvey Cushing, you will be struck by the ways in which that man's personality, his individual personality, has become a part of the culture of neurosurgery, sometimes for better and worse. But a lot of the sort of cartoon archetype, stereotype of neurosurgeons is because of that one guy. The assiduous focus on details, the precision. Harvey Cushing, to people who don't even read that book or know about Harvey Cushing, has left a mark on the field that very, very few people do. Nick is that. So I didn't train with Nick, but Nick's personality is a big part of me and how I approach vascular disease and academic neurosurgery. And my trainees have picked up, cultural attitudes and habits that are all Nick Hopkins. And so when you look, if you go to Jackson Hole or you go to the CV section and you watch how these young vascular people talk, you'll hear them say, you need to open the kimono. You'll see them sort of laugh wryly. You'll see that their particular approach to patient morbidity and mortality is a little bit of that dark sense of humor, but a lot of compassion. I think, people say that within 2 generations nobody remembers you. If we forget the name of Nick Hopkins, I am convinced that his attitude towards building the field, towards taking care of patients, and towards training the next generation has become completely grown into the soul of vascular neurosurgery in a way that very, very few individuals ever accomplish. And I don't think he set out to do that. I don't think he ever had this big burr up his butt that he really wanted to make the whole field of neurosurgery like his personality. It's because he had a wonderful approach to life. I mean, he was completely in love with Bonnie. He loved his kids. He really, really enjoyed, taking the piss out of somebody, to use the British idiom. He had a loving way of laughing, and he never backed down at all about anything. And he was completely collaborative. So in the vascular field, we've got these different sort of attitudes, right? And there is a group of neurologists within SVI that have a huge chip on their shoulder that neurology. And I think it's sort of juvenile, right? They just published a paper about how they can take out, clot out of the brain without a neurosurgeon. It's silly and provocative. Nick's not like that. Nick's provocative, but intensely collaborative. The reason Janata has his department like that is you heard it from him, right? In 1994, we did this. He was watching this. It's the reason my department is the way it is. It's the reason the Jacobs Institute is built with collisions between these different specialties as a part of the physical plan. So, I can talk about Nick's effect on me personally. I wouldn't have been able to do any of the things I did without all the little things he did for me. But I think it goes a long way beyond that.
I want to hear these 2 guys talk about that.
Well, definitely, Olad. He changed my life. I mean, I honestly, it sounds like a crazy thing to say, but as a medical student, really not knowing anything, he's one of these individuals which I don't think he ever will be forgotten because of first of all, the fact that we're sitting here talking about him now, but again, going back to intraarterial Avastin, MMA embolization, all of these things are built on really Nick's shoulders. And what he had this incredible ability. He was so affable. He was always so calm, and he could eviscerate somebody with just a couple words, and he would always have that smile, that smirk. And I'll sum it up with this: there's not a day that goes by either in the OR or in the endo suite that I don't think about him or kind of hear the voice. And the 3 things that always remind me of Nick are why not? No matter what, you could say the craziest thing and be like, well, why not? The second one was exactly that. If you're not ruffling somebody's feathers, if you're not agitating things, you're not doing anything meaningful. And then the third one, and I've come to him, God knows how many over the years with advice and this and that, was F him. When you think your world's upside down, it's like, F him. And he just had that affability of it's okay. He had the big picture, which I think is because he was so grounded. And from Buffalo, I'm from Buffalo, so he was a Buffalo guy, which he was humble.
I mean, how did he change my world? He made my world. I mean, in the sense of being a mentor, this guy, he was like a father. I love this man. And I remember before leaving Pittsburgh to go up to Buffalo, they said, you will learn more from Nick outside the endo suite than in. And it was so true. Things he used to say, God gave you 2 ears, 1 mouth, listen twice as much. You never know where brilliance will come from. Listen, look to everyone around you to learn. And then never let a day go by where you don't think about advancing care. And really that was why he built the JI with collisions. We work with cardiologists every day. We work with the EP guys. We borrow their technologies. He's integrated neurotechnology into our daily fabric, into our practice. Every day we're asking, where's the gap, right? Where's the knowledge gap? His vision was, can we make this so simple? We can do this outpatient on a street corner, and we're doing that now. The day he passed, the morning he passed, we did a live case to the CNS, and I walked into his room. I said, 20 years ago, Nick, you said one day we'll be doing outpatients awake, doing aneurysms awake in an outpatient center. Today is the day. And he heard me, he smiled, and later he passed later that day. But as Adam said, anyone who's been in his sort of radius, his proximity, he's touched them, but he has changed neurosurgery in perpetuity. We certainly lost a very special person last year.
Yeah, I don't have a lot to add to that, but I'm looking around the room. I probably trained farther ago than most people in this room. In an era when neurosurgeons weren't necessarily considered nice guys, and back then they were all guys. So, but Nick just embodied. And when people say, "Oh, who's Nick Hopkins?" I said, "He's the world's nicest guy, neurosurgeon." That's how he affected me.
And the last thing I want to say is too, if anybody, I would encourage anybody to go see the Gates Vascular Institute and the Jacobs Institute. There's nothing like it. You can describe it to people. There's nothing like it, and his soul is in that place. I mean, you have 18 IR suites with cardiologists, vascular surgeons, neurosurgeons interacting. And one last story that I have to tell. The first time it opened up, I went, and like any new hospital, this was a vision that he had, that he got across the line. We're standing up like outside his office, looking down into the central area. And for those of you that knew Nick, he loved coffee, and he would buy these like $10,000 coffee machines. And I said, Nick, I would never question anything. I said, but there's this like $7,000 Italian coffee maker down there. And I said, probably not the best, wisest thing. Your budget, I'm sure you've got to, you just got off the ground. I'm sure you guys are starting off with debt. And he said, Errol, what do you see? And I'm looking. Everybody was at the coffee maker, talking, interacting. He said, this is the collision site. This is a site of collision. This is what brings everybody together. And that's the epitome of Nick.
Well, thank you for that. My last question is more about, enduring lessons that he may have taught you. It can kind of go with what we just talked about. Something that you do in your practice that reminds you of him.
I mean, literally everything is just questioning what is possible and why not. I mean, for me, it's really that simple.
I've been on a lot of guys' ORs and angio suites, and when Steve says that Nick was the nicest guy in neurosurgery, his demeanor in regard to everybody else who was around was maybe the most humble I've ever seen in a neurosurgical leader. He was ready to listen and learn from anybody in the room. And so I'm not going to say that I do that, because I wish I was more like Nick, but I try to be like that, and I think about him in that way.
Yeah, you can be humble, but when you got to go nose to nose with Spetzler at every one of these vascular meetings, and he went nose to nose with Spetzler at every one of those vascular meetings extremely effectively, and that's what made Nick Nick. So yeah, he could be the nice guy, but he never let Robert get a leg up on him. That's for sure.
There's a Persian proverb that applies to Nick that loosely translated says that the branches that have the most fruit on them are weighed the closest to the ground. And that's why Nick could be both humble and go nose to nose with anybody.
Yeah, and what he did early in the day, when he didn't have a budget, he hired a medical editor. And then you have two medical editors at work. And he said, Nick, you're spending $250,000 to have these two people in the department to help residents and fellows write. And his point was, every day we're asking questions, and every day we're trying to move the needle. But if nobody hears us, and if nobody sees us, and data doesn't lie, if we're not sharing this with the world, what are we doing? And he's placed 50 people in academic centers and leadership positions in cerebral vascular. And, I was a young fellow, and I'm, Debbie Zimmer and now Carrie. But it was that kind of culture embrace, assess. If it's not good, move on, fail quickly. All these things I can hear Nick say, which are very similar to what entrepreneurs say. But also the cornerstone was academic integrity. We may be doing great things every day, but if nobody knows about it, what did we really do? How did we move the needle? How did we affect patient care around the globe? And that was sort of his raison d'etre, right? Every day he's like, we are going to change the world. What did we do today to change the world? Certainly said that with a smile, and he is a wonderful man, but nobody ever outworked that man, ever, ever, ever. Yeah, just a tremendous source.
And Dr. J, one of the things you mentioned early was about the travel club and like the travel club. We hear about travel clubs, and I know there still exist to this day, but it sounded from your perspective he was a central part of that. What was unique about that travel club? What did that mean to you guys?
First of all, I knew of a travel club because my old boss and chair was Richard Schneider, and he was part of a, quote, travel club. And back in those days, the travel club traveled, and it traveled to one of the members' medical centers. And when I was probably a fourth-year medical student, all of these neurosurgeons came to Ann Arbor, Michigan, and I'm looking at all these names, and they're all of the authors of the textbooks I'm reading, trying to learn how to be a neurosurgeon. Phenomenal. And this travel club, first of all, started off with potentially 40 members, which was, of course, some of us recognized that was ridiculous. One night, Spetzler and Sontag were sitting around, and on the back of a napkin put a bunch of these names, and many of us didn't know each other. I didn't know Art Day, who, as a few of you in the room know, he's one of my best friends ever. But we didn't know each other. I didn't know Nick at the time, but we became each other's best friends as a result of Robert scribbling names on a napkin. I mean, you can't make this stuff up, right? Our raison was to get together, the travel thing, and of course, with Robert as the sort of the titular head of this thing, you couldn't just get together and have fun. You had to get together, and everybody had to give talks and so forth. And so he made us do this, and then he'd say, we'd schedule 2.5 days of talks, and he'd say, let's get this done, and then we'd all have to give the talks all on the first day, so then he could spend the next day and a half having the fun that he wanted to have. So anyway, that was the soul. He was the soul of the travel club. And by the way, those guys are pretty old up there, and Art and I are the only two that are still practicing medicine, actually. So just. Oh, you don't want to see the hot tub?
I was given some pictures I selected. Well, I think that actually gets us right to the 3 o'clock hour. We all stand on the shoulders of giants, and with 4 giants in the field in front of us, who have their giant as well. So great. I felt honored that I even got to meet Dr. Hopkins through this Leaders Series. They're on the website. You can see 2 fantastic interviews. This will be also on the website. So I appreciate everyone coming out. I appreciate you guys spending the time to talk with us today, and thank you.